Good morning, good afternoon, good evening, depending on where you are. Welcome to this ecancer roundtable discussion on multiple myeloma after ASA 2020, in which we will have the opportunity to discuss about multiple targeted therapies with all information we have just coming from the end of the ASA 2020. My name is Marivi Mateos from Salamanca in Spain, and I would like to welcome to the expert that will be joining with me today in this meeting. Professor Beksaç from Ankara University in Turkey, Professor Kumar from Mayo Clinic in Rochester, Minnesota, US, and Professor Dimopolous from Athens University. Welcome to all of you, and let's evaluate the relapse and refractory situation, what it is becoming a bit challenging in the clinical practice. And I think that in the near future, most patients at first relapse will be exposed to proteasome inhibitor, to IMiDs, and I would say that almost all of them will be in principle then refractory, and I think that in the future, not in the near future, will be also refractory maybe to the anti-CD38 monoclonal antibody. But if we focus on relapse and refractory myeloma patients in the first relapses, anti-CD38 monoclonal antibodies naive, Dr. Dimopolous, what is the best option, or how do you plan to make the right choice, especially after, the presentation you did at us coming from the Apollo study with the data pomalidomide and dexamethasone, but we have also updates coming from KD plus daratumumab, KD plus isatuximab.
Yes, thank you. Although the Apollo trial was designed for patients who have received 2 or 3 prior lines of therapy, there was 10% of the patients who received this combination as second line, as you mentioned, after exposure to VRD. I think at this point, especially taking your point that most of the patients will be progressing on some kind of lenalidomide maintenance, in my mind, the most appealing combinations that we have are the combinations of calcifimab dexamethasone with one of the 2 anti-CD38 monoclonal antibodies. Candor has a longer follow-up, and we see that for LEN refractory patients, we have a median PFS exceeding 2 years, which is, in my mind, the best data that we have seen. And we expect similar data to see with in the IKEMA trial, where isatuximab was used with calcifimab and dexamethasone. So I believe if I have to choose, I think one of those combinations could be preferable for treatment of these patients. Of course, it is important that in the Apollo trial, for the first time, the combination of subcutaneous daratumumab with pomalidomide and dexamethasone was used as second-line treatment. And I think this is also a useful regimen for patients who have been exposed to frontline treatment such as VRD.
Okay, perfect. Thank you very much. And Professor Kumar, I have the millions question for you. Well, is there any special difference between the 2 monoclonal antibodies targeting anti-CD38, daratumumab and isatuximab? And do you have any preference by one or the other in any specific population?
No, I think we have seen no difference in terms of the activity. Now we have almost 2 sets of trials. We have the Candor and the IKEMA. We also have the ICARIA and the Apollo trial, which are very fairly similar designs with similar combinations. And we have seen quite comparable results between the 2 monoclonal antibodies. And even when you look at the early data with the single agent isatuximab and single agent daratumumab, the results are very similar in similar patient population. So to me, both drugs are pretty much interchangeable in terms of its purpose. Now, the question is, which one would you choose in any given setting? I think clearly with the POM combination and the carfilzomib combinations, either of them would be appropriate based on the 4 phase 3 trials that have been done. And what a particular institution might end up doing might depend on what is available in the formulary. Having said that, the subcutaneous formulation with daratumumab certainly changes the equation. There's certainly a convenience to getting a subcutaneous injection with daratumumab, and some patients and some institutions and providers may prefer to use that for logistical reasons. Again, the cost differential might be different in different countries.
Yeah, so excellent answer. And Professor Beksaç, well, we receive sometimes many questions, and even we can face with patients in the relapse situation, in challenging situations, especially patients with renal impairment, as well as sometimes patients with extramedullary disease. And we know that these patients usually are not basically included in the clinical trial. So sometimes we can't do formal recommendations. But at ASHA 2020, I think that you are the author of one abstract involved in this specific subgroup of patients, patients with renal impairment and extramedullary disease receiving pomalidomide dexamethasone plus isatuximab. Do you want to comment something about that in order to give clear messages to the audience about the potential use of this combination in these populations?
Yeah, thank you so much. Yes, certainly for patients who have renal impairment, it's among the IMiDs, pomalidomide is the most safest one. So with a monoclonal antibody and a pomalidomide combination, it certainly works. And with an effective regimen, there is also the potential to circumvent the renal impairment. Regarding for the extramedullary disease, in this Congress, there have been some couple of abstracts, including one of the faculty members, Kumar, has also another abstract, but with another combination excluding a monoclonal antibody. And extramedullary disease constitutes only a minority of patients. For newly diagnosed, it's about 10, and in relapse setting, it's even more. But in the ICARIA study, among 300 patients, there were 34 patients who had paroastose and extramedullary disease, so they are combined together. And 24 of those patients were the experimental arm. And we were able to compare the efficacy of this triplet in extramedullary disease, and both the response rate and the PFS were 3 or 2 times more for the response and 3 times more for the PFS. So it is an advance, but for advanced patients, it's not the curative approach.
Yeah, sure. And now we have to dedicate just some minutes to the new modalities, the BCMA targeted therapy, but not only BCMA, because we had the opportunity to see new targets in multiple myeloma. If we focus on the BCMA targeted therapy, well, we had the opportunity to see, I would say, a long list of CAR-Ts as well as T-cell engagers targeting in BCMA. Professor Kumar, any general thought about all these BCMA targeted therapy in terms of cell therapy? So T-cell engagers or CAR T-cells, do you want to pick up one of these as the favorite or the most relevant for you?
You mean CAR-T versus bispecifics?
Yeah, for example.
Yeah, no, I think 2020 ASH is going to be remembered as probably the inflection point in the immunotherapy. We've been talking about the promise of immunotherapy for a long time, but now we have cumulative data showing that this is really going to be the future. Now, my feeling is that CAR-T has most data in terms of durability of response so far. The bispecifics appear to be quite effective based on the results that were presented with 3 different targets now. But we don't have a good sense of the durability of the bispecifics yet, and also what could be the toxicity associated with long-term administration. The advantage of autologous CAR-T is the fact that it is a one-time thing. The disadvantage obviously is that it requires, it's not off the shelf, so you have to prepare the patients for it. So it's really hard to know which one is really going to take off. My feeling is that both of them are going to play a role. Maybe the CAR-T more in the setting of maybe earlier lines of therapy, and the bispecifics maybe in the later lines of therapy, especially in the relapse setting where patients are more likely to be taken care of closer in their community, which makes it easier to do a non-cellular therapy approaches.
Okay, thank you very much, Anna. Well, the last question will be for Professor Dimopolous. Well, I was quite surprised, but in a positive way, about the median overall survival reported in ID-cell, because Professor Kumar previously alluded to the lack of data in terms of durability of the response for the T-cell engagers. But 3 years of median overall survival after BB2121 in a heavily pretreated myeloma patient was surprising for me. Is it the same feeling for you? And can you comment on this data, because median PFS was of approximately 9 months, but the overall survival extended up to almost 3 years?
Yes, I think these results are very, very interesting, and we need to find an explanation on how these patients may respond to subsequent therapies in view of the short median PFS. So I believe that CAR T cells should not only be viewed as a modality that is associated with a median PFS of 10 months to 14 months, but also as a modality that may give the opportunity to the patient at the time of relapse, maybe to respond again to several lines of therapy. So I believe there are several things that we need to know, and definitely modulation of the immune system is playing a very important role in the management of myeloma.
And let's go to a discussion about the newly diagnosed myeloma patient. And if we focus first on the transplant eligible, I think that we have had the opportunity to listen some abstract in which I think that the role of autologous stem cell transplantation in this population is, I would say, under debate. And I would like to ask Professor Dimopolous, what is your perspective in terms of autologous stem cell transplantation? Do you consider that continues being the standard of care, or maybe this hot topic of debate will continue ongoing for the upcoming years?
Yes, thank you, Professor Mateos. I think that in this ASH meeting, we saw data which support that early autologous stem cell transplant is associated with an improved PFS, and also in some of the studies that have a long follow-up with improved survival as well. So I believe that early autologous stem cell transplant remains as a standard of care. Of course, we know that historically, each time we have new drugs or new approaches, this is a question that we pose. So far, it seems that high-dose therapy for myeloma is resistant and is here to stay. We don't know in the future. However, I believe that it should be included in the standard of care today.
Okay, Professor Beksaç, would you agree to conduct clinical trials in which maybe the risk status together with the minimum residual disease status will be incorporated into the treatment algorithms in order to plan again the role of autologous stem cell transplantation?
Yeah, I think so. It's in today's era, the importance of personalized medicine and patient-based decisions are becoming more and more important. And we have come to notice that there are some long-term survivors, even without transplant, and with transplant, they can survive in good remission more than 10 years. And so the question for these patients is, transplant still valid for those? And on the other hand, patients who achieve, let's say, MRD negativity prior to transplant, and after transplant, if MRD is negative, it is still questionable to pursue, because the question is MRD once enough, or is a sustained MRD more important? In this setting, I think there's a need for future trials, although there might be not so much interest in the audience. But the thing is, transplant is important. But for some subsets, maybe there are other modalities. And the EMNO2 HOVON trial has shown the importance of consolidation. So on top of the transplant, the role of consolidation is also very important.
Excellent. And a quick question to all of you. Standard of care for this transplant-eligible, newly diagnosed myeloma patient? RVD plus anti-CD38 monoclonal antibody, or maybe VTD plus daratumumab? Shaji?
I think for us, the combination of BRD is still the standard of care. We tend to use the 4-drug combinations only in the setting of high-risk disease because of the deep MRD that has been seen or high rates of MRD that have been seen with the quadruplets, and data showing that getting to be MRD negative is probably the most important thing for the high-risk patients. And I think the transplant still continues to be an important part. And I think the FORTE trial data confirms that the transplant still has something to offer, even when you use a combination like KRD.
Professor Dimopolous?
Yes, as you know, in Europe, we cannot still administer daratumumab in the frontline setting outside clinical trials. However, we have the possibility of VTD plus daratumumab. Now, whether VTD plus daratumumab is better than VRD remains to be seen. I believe that one of those induction regimens are appropriate for the treatment of myeloma. And as Professor Kumar mentioned, I believe that in the future, a quadruple combination, including a CD38 monoclonal antibody, may be of benefit, not only in the high-risk patients, which clearly may be indicated, but also in standard-risk myeloma patients, because we still want to increase the percentage of such patients that may achieve MRD negativity even after induction.
Professor Beksaç?
Based on the approvals in our country, VCD and VDT are the ones, and in some countries as well. But VRD is certainly better than these. And the role of the quadruplet, adding DARA, has been shown that even in high-risk patients, it decreases the gap, but it doesn't overcome the high-risk feature. So for this purpose, the debate is still ongoing.
Okay, thanks. And now let's move on to the transplant-ineligible population. And I would like to ask to Professor Kumar, because he presented an update of the MAIA study. And I think that this study will result, from my point of view, in the best results so far reported in the transplant-ineligible population. Do you consider that the DARA-Lendex should be the standard of care in the upcoming phase 3 clinical trials?
I completely agree. I think DARA-Lendex certainly, especially with the updated data now with the PFS, probably projected to go beyond 55 to 60 months, is the best that we have seen in the context of a newly diagnosed myeloma in the transplant-ineligible population. Obviously, we cannot compare across clinical different trials, but I think the data would support certainly the use of DRD as an initial therapy for this group of patients. Whether it should be used over and above VRD, it's a little harder to say in the absence of comparative data, but our approach has been to use DRD in the standard risk and continue to use BRD in the high-risk transplant-ineligible patients, primarily because of data showing that there is benefit of using a proteasome inhibitor in the high-risk setting. But one thing important with the follow-up data is now we see that both the high-risk and the standard risk appear to benefit in a similar fashion with DRD, which was not that evident with the early analysis.
Yeah, this is true. And I think that this is the second time the hazard ratio for patients with high risk is quite good. So definitely, I think that we need to have longer follow-up in order to evaluate from the numerical point of view the median PFS. Professor Beksaç, just a quick question about, well, something to which Dr. Kumar previously alluded to. 3-drug-based combination RVD plus the anti-CD38 monoclonal antibody in this transplant ineligible, because there are at least 2 phase 3 clinical trials ongoing, RVD plus daratumumab, RVD plus isatuximab. Do you see any specific population in which we can potentially select this combination, according to what Professor Kumar previously said?
Well, I think that even DARA-RD can be myelosuppressive, and there's a need to reduce the lenalidomide dose in the elderly. But in our experience with the ongoing IMRO study, for instance, is extremely good. So in the elderly setting, selected patients who have good performance status and who are in the fit range, they benefit from this quadruplet. But coming back to patients elderly and who has renal problems, in this setting, maybe the ALSA1 type of approach could be also kept in mind.
Thank you very much. I think that this brings up to the end of this meeting with, I think that a positive message, because, well, we are observing how the survival of our patients with multiple myeloma is clearly improving, basically thanks to the incorporation of new options of therapy, new targets. So thank you very much to all of you, and I hope you are enjoying this eCancer Roundtable discussion after ASH 2020, and looking forward to seeing you after ASH 2021, but maybe in a physical way. Thank you very much.
Thank you.
Prof Mateos.